Hello everyone, I'm Dr. Monica and welcome back to the Periodontology Master Series. In today's episode, we'll learn everything you need to know about dental calculus in a simple concept-based and exam-oriented way. So let's begin. So let's start with the definition. Calculus consists of mineralized bacterial plaque that forms on the surfaces of natural teeth and dental prostheses. So in simple terms, we can say that dental calculus, it is the hardened dental plaque that firmly attaches to the surfaces of teeth or dental prostheses, which can be denture, crown, bridges, or it can be implant supported prostheses or any kind of orthodontic appliance. So now let's understand the formation of the dental calculus step by step. So coming to the first step, that is the formation of the dental plaque, which is also known as the bacterial biofilm. So it is a thin layer of microorganisms that is formed on the tooth surface and it is embedded in an extracellular matrix. So at this stage, the plaque, it is still soft and it can be removed by brushing. So coming to the second step, that is the enzymatic activity by microorganisms. So as the plaque matures, the bacteria, they begin to produce several enzymes such as the lactate dehydrogenase, alkaline phosphatase and acid phosphatase. So what do these enzymes do? They promote calcification by altering the local environment and they facilitate the deposition of minerals. So we can say that calculus formation, it is an active biological process. So coming to the third step, that is absorption and concentration of minerals. Here the plaque now starts absorbing the calcium and the phosphate ions. So these minerals, they are mainly obtained from two sources, that is saliva, which is the primary source for the supragingival calculus, and the GCF, which is the major source for subgingival calculus. So as the concentration of these ions increases within the plaque, the conditions they become more favorable for mineralization of calculus. So coming to the next step, that is binding and precipitation of minerals. So what happens is the calcium ions, they bind to the carbohydrate protein complexes which is present within the plaque matrix, and once the concentration it reaches supersaturation, we can see that calcium phosphate salts, they precipitate, which forms the first microscopic mineral crystals, that is calcium phosphate crystals. So this is the beginning of plaque calcification. So next step is growth of crystals. So initially we can see that the crystal growth, it occurs in the intercellular matrix, and later crystals develop on the surface of the bacteria and eventually inside the bacterial cells. As more crystals accumulate, the plaque becomes increasingly mineralized. Next is the mineralization progression. So we can see that the calcification can begin within the 4 to 8 hours after the plaque formation, and around we can see that 50% mineralization that occurs in about 2 days, and by about 12 days mineralization it can reach nearly 60 to 90%. So we can say that if the plaque it is not removed regularly, it eventually becomes hard calculus, which cannot be removed by blushing alone. Next is the site of initiation. So where does the calcification actually begin? So in case of supragingival plaque, we can see that the calcification it starts along the inner surface of the plaque, that is the part attached to the tooth. And in case of subgingival plaque, the calcification begins in the attached plaque adjacent to the tooth. So from these initial sites, mineralization gradually spreads throughout the plaque mass. So coming to the factors on which the calculus formation depends, they are age, gender, ethnic background, diet, location in the oral cavity, the oral hygiene of the person, bacterial composition, the host response, access to professional cleaning, mental or physical handicaps, and systemic diseases and any kind of medications. So now coming to the composition of the dental calculus, it comprises both inorganic and organic components. And in the inorganic, we can see that the principal element, it is the calcium, followed by phosphorus, carbon dioxide, magnesium, and we can see there are trace amount of other elements. And the main compound here is the calcium phosphate. Then we have calcium carbonate, and in traces we can see magnesium phosphate compound. In the organic component, carbohydrates are present, and we have salivary proteins, amino acids, and in smaller amount we have lipids. So next is the classification of dental calculus. It is classified on the basis of location into supragingival and subgingival calculus. On the basis of source of mineralization, we have salivary and ceruminal calculus. On the basis of surface, we have exogenous and endogenous calculus. On the basis of initiation and rate of accumulation, we have non-calculus formers, slight calculus formers, moderate calculus formers, and heavy calculus formers. So coming to the supragingival calculus, it is the calculus which is located coronal to the gingival margin. It is white or whitish yellow in color. It is hard and it has a clay-like consistency, and it can be easily detached from the tooth surface on brushing. And the color of this supragingival calculus, it is influenced by contact with substances such as tobacco and food pigments. So most common locations for development of supragingival calculus, it is found to be the buccal surfaces of the maxillary molars and the lingual surfaces of the mandibular interior teeth. So coming to the subgingival calculus, it is the calculus which is located below the crest of the gingival margin. So it is hard and dense, and it is usually dark brown or greenish black in color. It is firmly adherent to the tooth surface, and the location and the extent, it may be evaluated by careful tactile perception with an explorer. So whenever there is gingival tissue recession, the subgingival calculus, it becomes exposed and it is reclassified as the supragingival calculus. So coming to few key differences between the supragingival and subgingival calculus, as we have talked that supragingival calculus, it is formed coronal to the gingival margin, and subgingival calculus, it is formed below the free margin of the gingiva. So coming to the source, we can see that it is derived from the salivary secretions, that is the salivary calculus. And the subgingival calculus, it is derived from the gingival exudate, that is the ceruminal calculus. So coming to distribution, we can see that symmetrical arrangement is seen on the teeth, more on the facial surface of the maxillary molars and lingual surfaces of the mandibular interior teeth. So in case of subgingival calculus, it is related to the pocket depth, and it is heavier on the proximal surfaces. Coming to the composition, we can see that in the supragingival calculus, we can see more brushite and octacalcium phosphate, and there is less magnesium with locite. And in the subgingival calculus, we can see there is less brushite and octacalcium phosphate and more magnesium with locite. So coming to other contents, we can see in the supragingival calculus, we can find less sodium content and salivary proteins are present. And in the subgingival calculus, sodium content, it increases with the depth of the pocket, and salivary proteins, they are absent in the subgingival calculus. Supragingival calculus, they are clinically visible, whereas the subgingival calculus, they are not visible on routine clinical examination. Coming to attachment, supragingival calculus, they are easily detached from the tooth, and subgingival calculus, they are firmly attached to the tooth surface. So coming to the crystal forms of calculus, we have four main types of crystal forms, which include the hydroxyapatite, octacalcium phosphate, magnesium with locite, and the brushite. So in the supragingival calculus, we can mainly see the hydroxyapatite and the octacalcium phosphate. And we can see in the subgingival calculus, magnesium with locite is present, and magnesium with locite, it is also present mainly in the posterior areas, whereas the brushite, it is mainly seen in the mandibular interior region. So next, let's understand the attachment of calculus to the tooth surface. So the calculus attaches to the tooth by four main mechanisms. So coming to the first, that is the organic pellicle interface. So in this, the calculus first forms on the acquired pellicle covering the tooth surface, and so the organic pellicle, it acts as a bonding layer, making it easier for the calcium salts and the bacteria to adhere. Second mechanism is mechanical locking into surface irregularities. So in this, the calculus mechanically locks into surface irregularities such as the resorption lacunae, any kind of caries, planing grooves, and microscopic irregularities. So this provides a strong mechanical retention for the calculus. Third is the close adaptation to the surface depression. So in areas where the cementum surface is gently sloping and smooth, the calculus adapts closely into the shallow depressions. So this intimate adaptation helps in firm retention. Fourth is the penetration of the calculus bacteria into the cementum. So the bacteria within the calculus can penetrate into the cementum tubules, and the calculus embedded deeply in cementum may appear similar to the cementum, which is termed as the calculocementum. So now let's briefly understand the theories regarding the mineralization of calculus. So out of the six theories, the most accepted one is the booster mechanism. In this, the bacteria, they act as boosters by concentrating the ions of calcium and phosphate and modifying the environment and providing the sites for crystal growth and maturation of calculus. Second is epitactic concept. In this, the crystals of calculus, they are deposited in a defined orientation in continuity with the crystal lattice of the tooth surface. Third is inhibition theory. In this, we can see mineralization occurs only at areas where inhibiting layer is missing or it is defective. Fourth is transformation theory. In this, organic components of the plaques, they are gradually replaced by minerals without keeping bacteria as the prime factor for calculus formation. Fifth is the bacterial theory. In this, the bacteria, they are essential for calculus formation by providing the foci for deposition of minerals. Sixth is enzymatic theory. In this, the bacterial enzymes increases the local alkalinity by hydrolyzing organic compounds, increasing the phosphate availability, and precipitation of calcium phosphate is favored. So coming to the role of microorganisms in mineralization of calculus, so we can see that whenever there is plaque bacteria, there is mineralization which begins around the bacteria, and some bacteria, they form intracellular apatite crystals, and the bacterial phosphatases, it increases the plaque pH. So the higher pH promotes calcium phosphate precipitation, and we can see mineralization spreads through the bacteria and the plaque matrix, and there is formation of calculus. So the viability of microorganisms in supragingival calculus, we can see that the microorganisms, they survive in the internal channels and lacunae of the supragingival calculus. And in case of subgingival calculus, the microorganisms, they survive in the deeper recesses of the calculus, and these environment, they favor periodontal pathogens such as Porphyromonas gingivalis, Dandruff forsythia, and Treponema denticola. So we can say that the fluoride, silicon, and urea, they act as promoters of calculus formation. So coming to the inhibitors of calculus formation, so the inhibitors of the calcification nucleation include magnesium and bisphosphonates, and the inhibitors of crystal growth in saliva, we have fluorine-rich protein and staterin and cystatins. So how can we detect the calculus? So coming to the supragingival calculus, it can be detected by direct examination, which is seen directly or indirectly with the mouth mirror, or we can use the mouth mirror along with retraction, the light, and drying with air. Coming to the detection of the subgingival calculus, it can be detected either by visual examination, by seeing the dark edge of the calculus, which is seen beneath the gingival margin. We can also use gentle air blast by deflecting the margin for observation. Next is the gingival tissue color change, which is seen during inflammation or pigmentation, may suggest the presence of subgingival calculus. Third is we can use a C21 probe, that is the tactile examination can be performed to detect the subgingival calculus, or we can use a fine subgingival explorer, which is also used to confirm the presence of subgingival calculus. So now coming to the systems which are used to detect calculus. The first one is the fiber optic endoscopy based system. So it is a minimally invasive periodontal endoscope that enters the periodontal pocket and provides a magnified real-time image of the root surface and shows the presence of residual subgingival calculus. Next is the spectro-optical technology based system, that is detector. This uses red light and optical signals to detect the subgingival calculus without tactile pressure. So next system is the autofluorescence based system, that is diagonodent. It is also used to detect subgingival calculus. So whenever there is presence of calculus, there is presence of fluorescence. So coming to the methods to remove calculus, firstly there is mechanical debridement, which can be done by using the hand instruments, or we can use ultrasonic scaler to remove the calculus and to smooth the root surface. Second is the vector system, which is a minimally invasive ultrasonic system with linear oscillation and fluid dynamics. So in this, the procedure irrigation with water is done, which activates the vector tip and removes the calculus and the biofilm, and we can obtain a clean root surface. Next is the laser ablation. So in this, the laser energy is used to vaporize or fracture the calculus with minimal damage to the surrounding tissues. Now let's talk about combined calculus detection and calculus removal systems. First one is the ultrasonic technology based system, that is PerioScan. So it uses an ultrasonic tip which is used to detect the calculus by different light and sound signals. So the blue light, it will indicate the presence of calculus, the green indicates cementum, which allows immediate ultrasonic treatment. So next is the laser technology based system. In this, the key laser 3, it combines calculus detection, and ER YAG laser is used to remove the calculus. So coming to the prevention of calculus formation, it can be done by reducing plaque formation. For this, we can use triclosan along with the polyvinyl methyl ether and malic acid copolymer, or we can either inhibit the crystal growth by using pyrophosphate, zinc compound, bisphosphonate, phytide, zinc ions, and vitamin C. So coming to the etiologic significance of calculus. So calculus, it is the plaque retentive factor. That is, it provides a rough surface which favors the plaque accumulation and retention, and it promotes gingival inflammation since it is difficult to clean. Also, its presence is associated with periodontal pocket formation, and it hinders in effective oral hygiene, and there is requirement of professional removal by scaling and root debridement. Also, subgingival calculus indicates difficult to clean areas, and plaque, not calculus, is the primary etiological factor, whereas calculus, it is a contributing factor for periodontal disease. If you have liked the content, please like, share, and do subscribe to this channel. Thank you.